Hello everybody. This webinar is presented by SEDS, Sussex Ehlers-Danlos Syndromes and Hypermobility Disorders Group based in Sussex, and positively provides specific funding in activities, therapies, and advocates strongly in all areas throughout Sussex and beyond. I am Jane Green, Chair and Founder of SEDS. Today, I am delighted to say we have Dr. Tina Pears, and even more delighted to announce she is our new patron. After qualifying in medicine at Guy's Hospital, Dr. Pears developed her skills in women's health, working as a GP, then becoming consultant in contraception and reproductive health, and leading these services in Surrey until recently. Last year, she established the Menopause Consultancy and a Centre of Excellence to provide evidence-based care for women. She uses her expertise in MCAS and histamine intolerance to inform treatment plans for those suffering from long COVID symptoms as well. So I'm really delighted to welcome her as our speaker today, and I'm now going to share the screen.
The title of my talk is Histamine Intolerance and Mast Cell Activation Syndrome, a Very Modern Affliction. And that's because we are way ahead of the curve of a lot of my colleagues in medicine who don't seem to even have it on their radar. So, and we are in a very sort of young state of investigation and research. So I'm afraid that we have to wait for some people to catch up with some of their ideas. So now let me just see how I advance it. There we are. So first thing I want to do is say thank you. I would like to thank you for inviting me to speak to you today. I'd also like to thank you for asking me to be your patron, and I consider this to be a tremendous honour, and I hope that it's not misplaced. I'd like to thank Jane and her team of volunteers who put such an excellent website together, because I had spent a long time yesterday having a look at that, and who fund and raise money to support sufferers of EDS in Surrey and Sussex. And I think you're doing a great job. And you're helping to put this on the map, which is really, really important. Now, what is the connection to MCAS? Well, a recent study found that actually 2/3 of EDS and POTS patients also have symptoms very suggestive of MCAS. And I suspect that most of you watching today actually know more about this than I do, because you'll have spent hours and days and weeks researching it and reading all the papers, and you'll have much more time than I have to look at it all. So between us, we probably have quite a good knowledge base. I believe that the mast cell is at the center of a pentad of syndromes. Some of you will have come across this nomenclature, the pentad. It's very commonly called that in America, in North America, so Canada and the USA. And there is an excellent lecture, 2 lectures by a doctor who is a pediatric cardiologist, and he's speaking at the EDS International Conference in Canada. And if you look at my website, I've got a long COVID document with information on it, and the 2 lectures, there are links to the 2 lectures there, which are amazing. And he talks about the pentad, and they are dysautonomia, EDS, MCAS, gastrointestinal dysmobility, and autoimmunity. And at the center of all of these is the mast cell misbehaving itself and causing lots of problems for people, which will overlap. Some will have just one area of dysfunction, and others will have a whole host together. So it's a very, histamine intolerance and MCAS are a very newly described condition, actually. The symptoms were first put together as being connected in the 1990s. And then it was finally given a name in 2007, when it was, when 3 case studies were finally published in the medical literature. So nothing appeared from the 1990s until 2007. And it is can be acquired and inherited. And then I just wanted to cover with you, why did I become interested in this? Well, it's a very personal story for me. Not because I've got it, but because my youngest daughter has it. So Jessie became very ill. Well, has always been ill since she was a tiny, tiny tot. And at the age of 3 months, even though she was fully breastfed, she started to develop eczema. And all through her childhood, I felt that she wasn't just it wasn't just eczema. She had this really pallor, really pale, always dark circles around her eyes, always a bloaty tummy. And she was such a good child. She never complained. So it was actually quite difficult to work out how ill she was. I think she probably got so used to feeling ill most of the time that she just thought it was normal, you know, and she didn't complain about it. And I'm afraid to say I didn't ask that much about it either, because I thought she was all right, although I knew there was something systemic going on. And everyone kept saying to me it was her eczema, and she was just had atopy. So a bit of asthma, lots of eczema, and that was the problem. And nobody really helped us with it at all. And then when she was 16, she became hypothyroid. And that followed an illness of swine flu. So she moved from her school to a sixth form college. And at the college, she caught swine flu. And she was really, really ill with the swine flu. And lots of you are going to actually, I'm sure, relate to what I'm saying. So infections make you very much iller than everyone else. And it seems to go on and on and on for much longer than it should. And she was ill for 6 weeks. She was absolutely knocked out by this illness. And that's when she became hypothyroid. So my theory is that the inflammation from the infection that she suffered actually ruined her thyroid gland. And that's very typical. I see it a lot in my patients. And then she had the added stress of going to college and being told that she was malingering and she was playing truant. And she wasn't playing truant at all. She was a very studious, very diligent girl, but she just was too ill a lot of the time to go in, because she had a migraine all the time, or she couldn't sleep at night, and she was exhausted. She had chronic fatigue coming on in waves, which would just sort of hit her. So she'd go in for the morning and then have to come home for the afternoon to sleep. And it was really disruptive for her and caused a lot of prejudice from some of the teachers too, which was really difficult. And it caused emotional, extra pressures that she didn't need. And then when she was 19, she got chickenpox, and she was again super ill with it for weeks and weeks. She was very, very ill for 3 weeks. And then after that, she sort of never quite got better. And each time she had a big infection, it set her off so that her baseline of health was worse. And then she'd have to operate from that, and then it got worse. So it was making her stepwise worse and worse. And then in 2016, she was so fed up of feeling ill all the time that she decided she would bullet superfoods, and she would drink all this green stuff that was full of healthy foods. So tomatoes, avocados, spinach, you name it, it was in there. And of course, these were all high histamine foods. And what she was doing to herself was poisoning herself, unbeknown to her and to us. So she'd moved away from home at that point, and was living with her fiance, and she was bulleting all this superfood, and getting iller and iller and iller. And first of all, she thought she had flu. And then she just got more and more ill. And she had more than 30 symptoms that were so debilitating. That's when I made the diagnosis. Now, 9 years before that, I had thought about histamine intolerance. Somebody had mentioned it to me, and I had looked it up on the internet, and there was absolutely nothing about it. Absolutely nothing. I couldn't find a thing. And that was because it was before these case studies had been published, and we just couldn't find any information. And I just sort of stored histamine intolerance away at the back of my brain. And then when she was super ill this time, and she seemed to be reacting in an allergic kind of way to everything, I sort of remembered it again and looked this time, and lo and behold, there was a bit more. There wasn't a lot, but there was a bit more on the information on the internet, which enabled me to feel fairly confident that I'd made the right diagnosis. And then many of you will relate to this. Having made the diagnosis, I then wanted to find somebody who could help us, because first of all, I'm not supposed to treat my own family. And secondly, I didn't know what the right treatment was to give her. I recommended fexofenadine, which is an antihistamine, and I thought that 180 milligrams was a pretty good dose. That's what I've been taught as a GP. So we managed to get her on that, but I didn't know what else to do, and I knew that she wasn't getting better. It was just awful. And I'd gone over to pick her up and bring her to our house to nurse her because she was so ill. And we went to see 6 doctors. 3 of them were top professors in London at a huge expense. And none of them had even heard of it and didn't know what the hell I was talking about when I started saying to them, this is what I think she has. One of them was a top professor of immunology and allergies, treating eczema all the time. So you would think he would know about it. And he sat there in his clinic, and he turned around to Jessie and to me, and he said, I think she's got a brain tumor, which was just horrendous. And I knew she didn't have a brain tumor. The poor girl, the look on her face, I shall never forget it. And I sort of managed to signal to her, like, he doesn't know what he's talking about, please don't worry. And we came out of there. I was so angry because he didn't know what he was talking about and caused so much worry. He charged me £860 for the privilege of telling us that. Anyway, we then found a lovely gynecologist called Vic Kular, who is a urogynecologist, and he sees women with interstitial cystitis. And bless him, Vic, when he took his careful history of all his patients, realized that there were some common themes, and that they all had histamine intolerance, and some of them had mast cell activation as well. And then he was the one who was gathering information and doing research and learning about this condition. And I found him completely by chance, and he helped us with Jessie. Now, I tell you that because I want you to understand that I do know what it's like to live with somebody who is going through these conditions, and it's incredibly difficult. So let's look at histamine very briefly in the body, and it's stored and released from mast cells, neurons, basophils, platelets, and in some enterographene-like cells in the stomach. And it has some important roles to play. So in the mast cells, it's important for our immune system. In the neurons, it's a neurotransmitter, especially for pain nerves. And in the stomach, it releases acid, which helps us digest our protein. So it's got some really important jobs to do. The mast cells also contain a whole load of other stuff. So heparin, tryptase, elastase 2, and hundreds of different mediators, which are supposed to be released into the body when we have an infection to help the body to fight that infection. So they all have a role to play and are important, usually to cause vasodilatation, so swelling of the area, and increased fluid in the area, which enables white cells to pass through. And then elastase 2 breaks down membranes, again, to help the white cells pass in to combat the bacteria or the virus that's causing the infection. And the problem is, when somebody has got high histamine, the mast cells think that the body's under attack. And so mast cells that aren't anywhere near the area that's breathing in the fumes or whatever start to also release these mediators into the bloodstream. And this triggers a massive histamine release. And then there are histamine receptors on various target cells and on the mast cells themselves. And high histamine causes toxicity. So it is important because it regulates a lot of processes, but where it needs to be kept in balance. And therein lies the problem. So it's important in the immune defense, in wound healing, in neurotransmission, in cognition, in our circadian rhythms, so our sleep patterns, and in wakefulness. So a lot of people get brain fog when their histamine is high because it interferes with all of that. A lot of people get insomnia because they can't sleep because the circadian rhythm goes completely to pot, and so on. And their thought processes are changed. It causes, as I said, the acid reflux in the stomach to digest the protein, and it helps us to alert our bodies when we are under attack, whether that's from an allergic reaction because of pollen attacking the body, or whether it's from an infection such as a bacterial or virus. Now, the body tries to keep histamine in balance, and that's what it wants to do, because it knows that high histamine is toxic to the body. It's like being poisoned. And once it goes over the toxic level, then it causes mass inflammation everywhere. So in all the organs, which is why Jessie's thyroid stopped working, because she had inflammation in her thyroid gland that ruined its function in the end. So the body has two enzymes that it uses to reduce the histamine and metabolize it away. One is called diamine oxidase, or DAO, and that is in the stomach and also the lungs and in the mouth and the nasal passages. And it is supposed to be released by the body so that when we eat foods that could be high in histamine, it reduces the histamine in those foods so that we absorb less histamine. And it's one of the body's ways of reducing the histamine intake because it doesn't want to be overwhelmed with histamine. And then in the bloodstream, there's one called HNMT, and that enzyme reduces the histamine that actually has managed to get into the body or has been released by the mast cells because of an allergic response or something. So it has to get rid of it. So that's how that works. Now, in 2 to 3% of the population, there are genetic mutations in the DAO gene and also the HNMT gene, which means that the production is compromised. And so these individuals don't make enough diamine oxidase, and therefore their body is constantly out of balance with histamine, which was why Jessie's body could not cope with the high histamine sludge she was drinking and eating every day. It was just overwhelmed, completely overwhelmed. And so her histamine just went higher and higher and higher and caused more and more inflammation in every single tissue. So that I will go through the list of symptoms in a moment, and you'll see how bad it can be. And so we also have depletion in some of the enzymes beyond the first step of the metabolism. The MAOA depletion can also occur, so that you don't get proper clearance of the histamine from the body. And this can lead to a lot of problems in the system. And this is just a sort of little snapshot of showing you histidine of conventional histamine, and then you've got diamine oxidase in the gut predominantly on one side, HNMT in the body. And if you see the orange little names, words are things that will make things worse. So caffeine and alcohol, for example, will block diamine oxidase. So the last thing somebody wants to be doing who's got low levels of diamine oxidase or high levels of histamine is to be having tea or coffee or green tea or alcohol or chocolate, unfortunately, and say the same thing. And the last thing these patients should be doing is smoking or breathing in somebody else's smoke, because nicotine really does inhibit the HNMT gene and enzyme. So that's really just gives you a little snapshot. Now, the company I use to do my genetic pathways for my patients is called LifecodeGX. And if any of you are interested in having your genetics done, please, please, please consider LifecodeGX, because I investigated so many companies before I chose them to do Jessie's genetics. And they are a nutrigenomics company that believe in only looking at pathways that can be influenced by vitamins and minerals. These are the cofactors that help the enzyme. So for example, on this slide, you can see DAO is helped by copper, B6, and vitamin C. So we know that if somebody has a compromised DAO gene, as in this case, there's a yellow and a green, so it's not two greens, then if we give them copper, B6, and vitamin C, that will help that gene that's very inefficient to become a little bit more efficient. And that's the basis of the pathways that they like to look at, so that they can really help people to understand their genetic predisposition to difficulties in various metabolic pathways. And if anybody does want to have any of their pathways calculated, let me know, because if I order it, I can get a discount because I'm a practitioner, and I pass that full discount on to any of the patients who want to have their pathways done. So do have a look at their website, and if you think I am interested in having something, just let Jane know, and then I can order it for you, and you pay them directly, and it's just gives you a saving of about £40 a pathway. So some foods are histamine liberators, so foods and additives, active drug ingredients and excipients included in some tablets and supplements as well can cause reactions and also release histamine. And then stress and anxiety and emotions can do it. Exercise, extreme exercise, so high intensity kind of exercise. Yoga and Pilates and things like that are fine and would be the thing that I would recommend mostly, but doing sort of really high impact work, jogging and pushing yourself is not a good idea, because that will release histamine in the body. Pressure and rubbing can also release it, and chemicals and fragrances. So you don't want those lovely room diffusers in your house and things like that if you have this condition. Now, there are also, as I said before, alcohol, tea and coffee and green tea. I had one lady and she confessed to drinking 8 cups of green tea a day, believing that she was helping herself because it's very healthy. And actually she was just poisoning herself because her histamine was just building up out of all control. Okay, so now we've got some typical symptoms here. So abdominal, and a lot of you are going to relate to this because 2/3 of patients with EDS have got mast cell activation and histamine intolerance. So I know that you will recognize a lot of these. So abdominal pain, diarrhea, nausea, and vomiting. So typical IBS symptoms. And I believe that anyone who says they have IBS has got this. Itching, sudden redness, so eczema, psoriasis, rosacea, but often flushing on the neck, flushing on the face. Palpitations, vertigo, arrhythmia, and hypotension. Often my patients confess to fainting when they have blood taken, so they have to lie flat to have blood taken because their blood pressure runs very low anyway. And then the stress of having some blood taken increases their histamine release, which lowers their blood pressure even more. So often they hit the deck. Runny nose, sneezing attacks, so rhinitis, asthma, and shortness of breath. Sometimes these patients are misdiagnosed as asthma and given lots of ventilators and things which only work for asthma and don't work for this kind of shortness of breath because it's slightly different. There's a slightly different mechanism going on here. Whilst both cause narrowing of the airways, one is by inflammation and the other one is by constriction. So pure asthma is by constriction, and in histamine intolerance, it's by inflammation because everything becomes a bit soggy and wet, and then the air can't pass through the airways very easily. Headaches, because of vasodilatation caused by the histamine, you get headaches, migraine, sweating, freezing, menstrual pain. That's the other thing. Often a very strong history of very severe cramping with periods. Dermatographia, there is no other cause for dermatographism. And that is where your face, your skin is red and blotchy, and if you can sort of write on it, so people can write their names across their foreheads, and it looks pale from the pressure and stays there for 20 minutes. And Jessie had lots of dermatographism when I made the diagnosis. Anxiety, panic attacks, and insomnia. Now, what happens is the body knows that adrenaline will reduce histamine. And so it releases more adrenaline to try and bring the histamine down, but that gives you anxiety and panic attacks. So, you know, that's what's going on there. Hypermobility, 80% of patients with histamine intolerance have hypermobility. 30% will have interstitial cystitis, which is why Professor Vitkula knew about it. They will often give a history of severe reaction to insect bites, aching muscles, aching joints, chest pain. Now that's an interesting one. When Jessie was 7, she started developing angina. And I was absolutely sure from the history and the description and seeing her have it that she was getting angina. And it would last 10, 20, 30 seconds and then pass. But it was so severe, she had to stop whatever she was doing. And she could be sitting still and getting it. And we had her checked out fully by a pediatric cardiologist, and her heart was absolutely tickety-boo and fine. And then more recently, when I made the diagnosis, we Googled it and searched the papers, and there is a paper which describes angina and constriction of the coronary arteries in people with high histamine. So that's what she is actually experiencing. And she knows when her histamine is really high, she may get this pain. She knows that it's angina. They often give a history of food intolerances, all sorts of foods that they'll say, oh, well, I don't eat that anymore. I can't have a takeaway, can't have any supper, you know, TV supper type dinners, can't have leftovers. That causes a problem. It's always worth asking patients about their general anaesthetic experiences, and also local anaesthetics can do this too, but especially general anaesthetics and their recovery after general anaesthetic. And that's because some of the anaesthetics that are commonly used raise your histamine and cause an absolute avalanche of histamine during the operation. So the poor patient during the operation has got this histamine cytokine storm released by their mast cells. And so that's going to give them a tachycardia, a rapid heartbeat, which will cause major confusion to the poor surgeons who will think this patient, and the anaesthetist, they'll think this patient is bleeding from somewhere because their pulse rate's gone up, and their blood pressure will drop, which will make them think even more that this person's hemorrhaging. And actually, it's not at all. And they may even make the operation longer than it should be because they'll be looking for these bleeding points that actually don't exist. which of course means they get even more of the anesthetic to cause even more problems. And then when they wake up, they feel absolutely awful. Headache, nausea, vomiting, can't move, dizziness, tinnitus, absolutely dreadful. And it can last for days, if not weeks. So the poor patients can have a real problem. And the Royal College of Anaesthetists has put a leaflet together. In 2014 they did this, which is meant for patients with mastocytosis. Now, mastocytosis is where you have an abnormal number of very abnormal mast cells, and they look abnormal under the microscope. In MCAS, that's the mast cell activation syndrome, they don't look abnormal, and they can't become cancerous, rarely. The mastocytosis group can become cancerous. But anyway, the anaesthetists recognize mastocytosis. They probably don't know anything about MCAS, but they have put together some guidelines for mastocytosis patients. So patients who have unusual mast cells and the way they react to an anesthetic should have certain anesthetics. And in all my patients who I have given this leaflet to, because I know they're going for a hysterectomy or going for an operation, and when they've managed to insist on having this specific anesthetic, they thank me so much, because they come round and they say it was like waking up from a nap, which is completely different to their previous experience of anesthetics, which have been so horrendous. So that's worth remembering. Patients have severe reactions to illnesses. So whether that's, the Epstein-Barr virus, so glandular fever, or chickenpox like Jessie had, or swine flu, or whatever, they have a really bad reaction. And chronic fatigue. So I think all the patients with chronic fatigue have got this. Bloating and fluid retention, strong sense of smell. That's the other thing, really interesting. You can ask yourselves, do you have this? It's very strong sense of smell, so that, when you walk in through the front door, you can smell something off in the bin, which is in the kitchen, which is behind 2 more doors, and everyone else in the family can't smell it, but you go, there's something off in this room, I can smell it, and you can find it. In fact, you could, people with this sense of smell could all become perfume designers or wine buffs, because their sense of taste is usually very acute as well, or they could work at Gatwick Airport and sniff out drugs in the suitcases, because their sense of smell is so strong. They also have sensitivity to loud noises and bright lights, and cut labels out of their clothes, because their skin is very sensitive too. So it's like all your senses are heightened. More symptoms: hair thinning, inflammation causes the hair to fall out, and this can be an absolute bummer. Really difficult to treat, because you have to keep the histamine down for prolonged periods of time to actually affect the hair cycle. Bumps in the nails indicating severe inflammation affecting the nail bed, and these are horizontal bumps and grooves across the nails, not longitudinal, horizontal. B12 and folate deficiency, very common. Angioedema, especially the eyes, the lips, and the face. Very easy bruising. When Jessie had very high histamine, if she just touched herself, she would give herself little fingerprints of bruises on her chest. Heartburn, very typically excessive acid production in the stomach. Depression and obsessional behaviors can occur, and also possible auditory hallucinations. Now, this is because it's a neurotransmitter. And when Jessie was 3, I remember her having a horrible ear infection. And so she was really ill with it, very high fever. And she said to me, Mummy, I can hear somebody talking in my ears. And I said, oh dear, what's going on? And she said, what can you hear, darling? And she said, I can hear my own thoughts, but said out loud by another voice, not my voice. And I thought, oh my gosh, she's febrile, her temperature's gone so high, she's hallucinating with it. And it was only when we realized about the histamine that I think it occurred, because her histamine was so high with the infection. It was a neurotransmitter, and it was actually making the thoughts fire and her auditory center fire as if she'd heard her thoughts. But the voice was distorted. And now as she's older, she gets that occasionally when her histamine is very high. So that's, yeah. And Vic Kula has a theory that 1/3 of people who are diagnosed as schizophrenic actually, and hear voices, actually have this condition. And if you treat them with the correct treatment, then they will stop hearing the voices. So that's another piece of work that needs to be done. Okay, so this condition, obviously from that list of symptoms, you can see it can present in so many different ways and very unspecific symptoms. And lo and behold, when everyone has their blood tests done and their x-rays and everything, it all looks normal. So these poor patients, they find themselves being referred for their IBS to a gastroenterologist who will look at their gut and take biopsies and say, oh, it's all normal. And then they'll go to a neurologist for their migraine who will do lots of tests and say, oh, it's all normal. And yet they've got terrible tinnitus, they've got, postural migraine, and et cetera, et cetera. And nobody comes away with any diagnosis or with any possible treatment, and therefore no hope of feeling better, which is really demoralizing and incredibly painful for these patients. And I've seen so many patients, because obviously making the diagnosis in Jessie in 2016, I then could not help but diagnose it in people. And I would come home, the first week after diagnosing her, I'd come home from work, from my family planning clinics in those days, and I would say to my husband, I've diagnosed 7 people this week. And he'd say, no, really? And I said, yeah, 7 people who I was taking a history from who fitted this and have been struggling for decades or, years. And I'm going to see if, helping them the way I've helped Jessie is going to work. And lo and behold, they'd come back and they'd say, you've transformed my life. I now don't get all those awful migraine, or I can work, or I've got more energy or whatever. So it was very compelling, and you just cannot help but diagnose it when you know what you're looking for. It's as clear as anything. But unfortunately, my colleagues who are very much siloed into specialties only look at one bit of the patient. And because they haven't learnt about this or heard about this, they don't look for it, and they don't look as at a whole at somebody. Anyway, so symptoms can be triggered by a meal, for example, or smelling a perfume, or walking behind somebody who's smoking a cigarette. They can appear 15 minutes or 4 hours after the trigger, and sometimes even the next day. So the histamine starts to go up, 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 and it's only when it goes over the toxic level that patients then are aware that the histamine has gone up. And 80% of affected patients are female. Often around the age of 40 is when it tends to present. And I see a lot of women with it who are perimenopausal. And the reason for that is that their estrogen levels start to fluctuate wildly. So when the estrogen goes up at the perimenopause, as well as dropping right down, it changes your histamine in your body. The histamine and estrogen are very interrelated. And when one goes up, the other will go up. So if you've got high estrogen, your histamine will go up. It also, estrogen blocks diamine oxidase production, so it's not great. So very often these women come and present with all these symptoms. They're given HRT because it looks like menopausal symptoms, the flushing and the palpitations and insomnia and so on, headaches and so on, very, very similar. And they're given HRT and it makes them worse, because they've been given estrogen without addressing the histamine issue. So one has to address both. Certainly tackle the histamine. When that's calmed down, then we can gingerly give some estrogen to help with them with their menopause symptoms, because they'll get those too. Okay, so often in the past medical history, there is a similar problem in other family members. Always worth asking this. Does anyone in your family have IBS or fibromyalgia or chronic fatigue, eczema, psoriasis, rosacea? And so often the patient will say, oh yes, my dad has always had gastric problems, terrible, terrible, terrible trouble with his stomach and acid reflux and so on. Often the patients have symptoms from childhood, which I've said, and increasing. I'm going to hurry along a bit because I've been talking already for quite some time. And they often give a history of progesterone sensitivity. The women don't get on with the combined pill or the mini pill. Sometimes they don't get on with the Mirena, which has got progesterone in it, and that can be an issue when we're trying to give them HRT. Even natural utrogestan, natural micronized progesterone, can be an issue. And sometimes I have known women with this condition have a hysterectomy so that they don't have to take the progesterone, and they can just have the benefits of the estrogen because they can't tolerate the progesterone. So very interesting. Often there's unexplained pleural clotting, miscarriages because of inflammation in the uterus. So the poor little ovum can't attach properly, the placenta can't attach properly, a history of depression, hypothyroidism, and severe infections. So we look for all of these things when you know what you're looking for. Okay, so mast cells are found everywhere, and they occur after injury as well as infection. And also other stimuli, which they should not be bothered with, they are being bothered with. So that's when your mast cells are slightly dysfunctional, and it releases these cytokines and chemicals inappropriately from a small stimuli that it should just be ignoring. And that therein lies the problem. Okay. And as I say, most of the tests and things are completely negative. Now, this stuff you will know, so we can skip through this very quickly. You've got, with Ehlers-Danlos, genetic mutations, most of which have been identified, which produce problems with the collagen and the proteins interacting with collagen, so that you have tissue instability, elasticity, and poor cohesion. Now, one of the products that is, one of the chemicals that's released by mast cells is elastase 2. And I think elastase 2 is something that we're going to hear an awful lot more about, and it causes membranes to disintegrate. And I have a feeling that it's got quite a role to play in Ehlers-Danlos, but we need to do more research into that. And if you look at those two lectures called the Pentad, you will see the elastase 2 coming up, and his thoughts on that, which are very interesting. It's there to make the membranes permeable to help the white cells pass through and help in infection, but it can, if it's too high, then it gets out of control. The RCGP toolkit for EDS is absolutely excellent. I'm sure you're fully aware of this, and Dr. Emma Reinhold, who I know, put that together. She has a vested interest, and she tells people this. She has got EDS herself and MCAS, so that's why she's just so interested in it. And she is a great person for writing articles and researching things, which is fantastic. So she's a great contact. And I would say that this toolkit is super important for your GPs, because my experience of GPs is they don't know very much about it at all. And if I tell them about it, they just think, who are you? And they sort of don't take it necessarily as being very mainstream. They think I'm a little bit maybe sort of like an alternative doctor. And actually having the RCGP toolkit for EDS is absolutely excellent, because it puts it on the map with the Royal College of GPs. So now I've started putting that at the bottom of all my letters to the GPs, saying, please, if you'd like to look, for more information, look at, and I'm hoping that that's going to make them sit up and take notice, more notice. And there's a section in there on MCAS. Emma managed to get that in, so that was really, really good. Now, there's loads and loads of tests that, in theory, one could do, but actually, it's not easy. The labs in the UK are not set up for these kind of tests. And so we end up with biopsies looking at the mast cells, and if there's more than 20 per high power field, when they are stained with something called CD117, then that's the diagnosis. The other way is the DAO enzyme activity in the serum. Now, that's a simple blood test. It has to go off to Belgium to be tested in a lab there. It's not available on the NHS. It's only available privately. It costs about £85. And in fact, I think there's a DAO test you can get online now, which is about £49. They've sold out at the moment, one of my patients was telling me, but watch out for that, because it'll be back. The diamine oxidase enzyme, it's slightly frustrating. The labs report that you have to have a level less than 10 for the diagnosis. And when Jessie was super ill, her level was less than 2. It was undetectable. So she had no diamine oxidase. So as soon as she was producing any, it was being gobbled up by the histamine in her system. So it registered as less than 2. And on the lab report, they say less than 10 it's probable. Over 10, it's not likely. But that's not true, because 6 months later, when we checked Jessie's again, having put her on a low histamine diet and giving her all the type 1 and the type 2 antihistamines and keeping her as well as we could, so her mast cells were calmed down, her level was 23.5. Now, the normal level is 30 to 60. So you know, anything below 30 is abnormal, and it will vary day to day. So if she was having a good day, it might be 23. But if she then had some stress because of an essay that needed to be handed in, or you know, somebody was smoking standing in front of her, it would go up. The diamine oxidase the histamine would go up, and the diamine oxidase would drop into her boots very quickly. So just vary second to second. So you cannot rely on a lot of these tests. And also, these mediators that are released by mast cells don't stick around in the blood for very long. They're gone very quickly. So it's not an easy diagnosis to make. So you have to make it on the history. And then I think it's actually very easy to make. So you make it on the history, and the treatment is broadly the same for everyone. With obviously individualized, but the principles are the same. So I don't get too hung up about actually getting lots of levels and things like that. Okay, now, okay, we've said all that. Stool tests, urine tests, the labs don't know how to handle it. It's not very easy. So we have to, I'm just going to brush through this because I want you to have some chance to ask some of your questions. So, right. Okay. LifecodeGX. This is interesting. This is the company that I was telling you about, that I'm very happy to order the test for you if you want. We managed to get Jessie reasonably well, so that she had more good days than she had previously, but she still had more bad days than good days. And my New Year's resolution this year, was at Christmas last year, was to really try and sort her out, to really drill down and know what her genetics were doing. Because an awful lot of these patients, you'll see this in the Pentad lectures, they have methylation and histamine issues, and B12 and folate pathways they're not working optimally or very efficiently. And I felt we really needed to know. So she was taking loads and loads of vitamins and minerals, and I just wanted to make sure we weren't missing some out or giving her something that wasn't going to be helpful. And by having her, we did her thyroid, estrogen, methylation, and histamine pathway. If I was going to do it again, I would also get her nutrition report, because that's very helpful, and maybe the detoxification pathway as well. Anyway, we did a few, and the information came back. Now, she'd had a liver function test done prior to us getting the result, and it showed that she had abnormal liver function. So her liver was not very happy. She had a raised ALT and AST, and that really worried us. We then got the results of her genetics, and we could see where specific problems were in her metabolism in the liver. And we gave her a few more very specific vitamins and minerals to help. And 6 weeks later, not only did she look and feel better, but her liver function tests had gone to healthy normal, from being abnormal and worrying, to being completely healthy and normal. So that was amazing, a 6-week turnaround, just by giving her body the support that it needed, which was incredible. So now she is, I would say she has probably an equal number of bad and good days. So we're sort of getting there. A little while ago, she was being very, very good with her diet, and she actually had more good days than bad, which was a real breakthrough. But also I would say that her bad days are not as bad as they once were, and they don't last as long as they once did. So we are definitely winning and going in the right direction. Okay, now, the elimination diet, very difficult. Have a look at the Swiss website, because they do categorize foods into no histamine, low histamine, medium and high. And that's helpful when you're making your choices. So we followed that guidance very carefully. And she doesn't have any alcohol, she doesn't have any tea or coffee. Occasionally she has a cup of tea, much to my annoyance, but she's human. There are certain fruits that she's allowed to eat, so she can have blueberries, blackberries, grapes, melons but not watermelons. This is the same for all patients with histamine. Apples and pears, nectarines and peaches, passion fruit and pomegranate fruit, and cherries. but she can't have the strawberries and all those kind of things because they're raspberries, they're very high in histamine. So cutting that out of the diet is very helpful, and then giving her, I'm just moving on here, some antihistamines. So here we go, type 1 and type 2 antihistamines and a mast cell stabilizer such as montelukast or ketotifen can be very helpful. And sodium chromoglycate, if you have a lot of IBS type symptoms, can be very helpful to help the gut, because that's a mast cell stabilizer that affects the mast cells that line the gut. So we can do that. And another thing that's can be helpful in 30 to 40% of patients is diazepam, or Ativan, they like to use in America. But diazepam, 2 milligrams a day, up to 4 times a day, can be very helpful. And that's because it sits on the receptors on the mast cell and it calms them down. So, and interestingly enough, patients who use it for this and respond well to it don't become addicted to it, because it's a benzodiazepine, so it's potentially addictive, and they don't get withdrawal symptoms when it's removed. A little bit like giving somebody morphine for pain, because it's sitting on the pain receptors, it's not going around the body doing any mischief, making them addicts or anything like that. This is some of the supplements that are very helpful. So you might want to think about these. Low dose vitamin C has to be a slow release one, or if you have an ordinary release one, just 3 times a day. Vitamin B3 niacin, this is just amazing. Niacin is called NAD+, and it is an incredible vitamin. And I can see that I've put vitamine, which, sorry about that, is a spelling mistake. But it's an incredible vitamin. Now, NAD+, those of you who are interested, is vitamin B3. It's called niacin, nicotinic acid. It is, it and its metabolites have a critical role to play in the regulation of the environment for cells. So our cells are super sensitive to the environment that they find themselves in. Every cell in our body wants equilibrium. It wants to be in a very sort of happy, safe environment. But things are constantly changing in our bodies. So our vitamin supply, depending on our meal, our hydration, depending on how much we've drunk or haven't drunk, whether we've got an infection or inflammation, xenobiotics, which are chemicals, so pollution, fragrance, antibiotics, drugs, supplements, excipients, these are all xenobiotics. So, and then we've got genetic problems. Sometimes our genes go a bit funny, and some of the cells then, you don't want the cells to respond to those genes. So you need niacin. So if nothing else, we should all be on niacin, vitamin B3, get the no flush type. L-glutamine is very helpful, and acetylcysteine is helpful. Quercetin is a natural mast cell stabilizer. That can be very helpful. Toxaprevent is an interesting substance. It is made from volcanic rock, and it's a bit like charcoal. It passes through your gut, does not get absorbed by the body, but it has a huge molecular structure with a massive hole in the middle that attracts heavy metals out of your body, out of your liver, into this place where it captures them, and then it takes them away. So it clears toxins from the body. It also clears histamine, so it's very useful to remember Toxaprevent. And also we have diamine oxidase, which can be eaten before meals, 20 to 30 minutes before a meal, which is made from pork, from pigs, diamine oxidase. So it's not human, and it will help to reduce the histamine absorption, and is useful if you're going to eat out or you can't control the diet that you're going to have. Saunas help. That helps to sweat out the histamine and reduces bloating. Body brushing is a good thing to do, and there's a course called the lightning course, which some people find helpful. And this is just some doses of some of the medication that we can use. So the antihistamines, type 1 antihistamines, can be bought over the counter, but on the Claritin or Zyrtec, it will say once a day, daily dose, once a day, but actually that's not enough. So in patients with this condition, we need to be taking it twice a day or even 3 times a day to stay on top of the histamine and block it from the receptors. So there we go.
We have some questions. There was so much there, so that was great. The first question is, what is the importance of differentiating between histamine intolerance and MCAS in terms of treatment, supplements, and dietary changes?
There is no difference at all. No, none whatsoever. So they sort of come together. So I think that, you know, we've got 2 to 3% of the population who don't make enough diamine oxidase. If those patients are living in a very high histamine environment all the time, their mast cells, which could be completely normal, will become activated and abnormal. They will become dysfunctional and overreact. So in theory, those patients, if we can calm down their histamine and calm down their mast cells, should go back to being a more, more level and even and better. Although they'll never be perfect because they don't make enough diamine oxidase, so they can't have a completely normal diet. But then you've also got the group where they've also, you know, they've got that 2 to 3, they've got that genetic predisposition, but they've also got abnormal mast cells, dysfunctional mast cells. And the treatment is the same because it's all about histamine. It's all about the release of all these chemicals into the body, which then cause the problem. It almost doesn't matter what source they've come from, whether it's EDS, you know, mast cells causing EDS, or whether it's mast cells causing histamine intolerance or whatever. It's the treatment is the same, and as is for the long COVID patients now.
So interesting, isn't it? You know, even if you didn't have it, we've got people who don't have it, didn't know anything about it a week ago, and they're just absolutely hooked, I can tell you.
Yeah.
Is there a specific test to diagnose MCAS if you suspect it, or should you just start on treatment anyway, i.e. management? And I think you've touched on that already.
Yes, management is the name of the game. Because, you know, if the one thing you could do, if you've ever had any biopsies taken, you could ask the path lab to re-look at those biopsies, because they keep them, and they could restain them with CD117 and have a look and see if there are 20 mast cells per high-powered field, and that would give you a diagnosis. So you could do that. You could also just have a blood test and check your diamine oxidase, but you want to do it when you're not on a low histamine diet and you're, you know, feeling a little bit histaminic, because then you're going to more likely get a result that everyone's going to believe.
Thank you. Yeah. Well, of course, we hope they will believe. Right. I'm going to try this. My pronunciation today is not great. What are your thoughts? And I think you've touched on this again for HRT, for people with EDS and MCAS. Your understanding adenomyosis is likely estrogen driven due to excessive mast cell reactivity. Yes. She had a hysterectomy.
She had a hysterectomy. Okay, so if somebody's had a hysterectomy and they've got these conditions, they're in a good position because they don't need to have the progesterone and they can just have the estrogen. So we have to try and do both. We try and control the histamine side of things to lower the histamine pressures on the body, and then also give some estrogen. Now, the other thing to remember is if you're on estrogen only HRT, you are in a very blessed position because the estrogen actually reduces your risk of breast cancer by 30%. Okay. So there's no negatives about being on HRT if you've got no uterus and you're not having any progesterone. And that's really, really important. We know that mast cells are very connected to a whole load of gynae issues. And actually, Professor Vikula has got 4 research fellows working on the connection between endometriosis and mast cells at the moment, because it seems like there's a common link with endometriosis, also possibly with polycystic ovaries, and with adenomyosis. So we're, you know, and certainly with painful, heavy periods. So we're looking at all of that, or he's looking at all of that with his research grant money. So that's great. He's got 4 people looking at it.
That's a lot. Good. Brilliant.
Yeah.
I'm sure that would be really useful. What about vaccines? I've got a question here on vaccines. Does it trigger MCAS?
Oh, this is a difficult one. We don't know the answer to this. We don't know the answer. We don't know. But I mean, I'm sure a lot of people with MCAS have had vaccinations in the past and have been okay with them. And I think that's what we have to sort of hang our hat on, really. I think if I was going to have the vaccination, which I will do, I would have the Oxford one, because that's been in development since 2012. So it's been around, sort of being developed for a long time, since the previous SARS infections. So I think I would go with them. And the fact that it doesn't have to be at -70 degrees, so you're less likely to have problems with the transport, et cetera, et cetera. And so I think that I would go with that. I think that I would be happy to have the immunization if patients are on the treatment. Just as we would expect patients with MCAS and histamine intolerance who are on the treatment, if they catch coronavirus, they should get it mildly or moderately, not severely. But there is a theory, and I am inclined to agree with it, that patients who get coronavirus and end up being in ITU and very seriously ill are patients with undiagnosed previous history of MCAS, who are not being treated, it's not been recognized, not diagnosed, not being treated. And then when they get the infection, their mast cells go completely crazy and cause all the inflammation that is causing the problems and causing a lot of people to die. And even in the biopsies, they've looked at some biopsies of the lungs in some of these patients, and they have got so many changes at the cellular level that suggests it's the mast cells that are the issue. They've got fibrosis, they've got deterioration and disintegration of membranes from the elastase too. You know, it fits with the picture. It fits with the picture. Yeah. Now, a little anecdote here, and I know it's only 2 patients. I had week before last, I had a patient who was booked in for a HRT consultation, and she came up on my Zoom screen and she looked dreadful. She was coughing. She couldn't get a word out. You know, every time she opened her mouth to talk to me, she just coughed and coughed and coughed. She looked terrible. And I said to her, look, she said, I'm so sorry. She said, I know you're really difficult to get in and see, so I didn't want to cancel. But I'm really ill. And I said, oh my God, what's happened? And she said, I caught coronavirus. And she said, it's been terrible. And she looked really in a sorrowful state. She said, I've got coronavirus. And she said, my husband is sort of getting better. My son only had it for a couple of days and is much better. She said, I'm getting worse and worse and worse and worse. And I've had it for 10 days and I am terrified. And she could hardly breathe. And I said to her, right, okay, we're not going to talk about HRT, obviously, but I'm going to tell you what I want you to take now. And I wanted her to take I wanted her to take NAD+, so the vitamin B3, the niacin, no flush, with zinc. Okay, so 15 to 30 milligrams a day of zinc, with selenium, either 2 Brazil nuts or 100 micrograms a day of the selenium. And what else? Quercetin as a mast cell stabilizer. I wanted her to take, she had antihistamines in the house, so she had loratadine to take 10 milligrams 3 times a day. And then I prescribed her a type 2 antihistamine. And so she started on those, and then I rang her up. That was on the Wednesday. She started on them on the Thursday when they all arrived. And on the Sunday, I rang her because I was so worried about her to see how she was. And she said, you wouldn't believe it. She said, within 24 hours of starting the medication, she started to feel better. She said, I could just feel it. It was all just calming down. And then within 48 hours, she felt well enough to get up, get dressed and have a shower and everything. And she said she just couldn't believe it, how different she felt. And my son's friend, one of his friends, rang us and said, I'm feeling terrible. Your mum's a doctor, you know, to my Ben, who was living with us at the time. You know, what shall I do? I've got this coronavirus and I feel absolutely dreadful. He was in bed and we were talking to him he was lying in his bed. He was in Austria actually. And I said to him the same thing, you know, take this, and get on it straight away. And within 24 hours, he started to feel better. Now, it could be a coincidence, but I think the treatment is so safe to take and cheap. We should be trying it on everyone who catches coronavirus. We've got nothing to lose, have we? Nothing to lose.
Can I just ask one thing there? You said about Brazil nuts and selenium. What if you're IgE mediated allergic to?
Oh, well, that's a problem, isn't it?
Yes. Just saying from my perspective.
Yes, you might have to leave out the selenium.
Okay.
But you could take the rest. You could take the rest.
Brilliant.
Yeah.
Okay. I can't. Yeah, I mean, it sounds like this almost like a sort of box of, you know, remedy. This is, let's try this and see where we go.
Absolutely. It's the, you know, it's also, I don't know, I would love to, I work with this company called People With, who are an app, and I would really encourage you to download their app. It's people with written as one word, and it's a fabulous app, and it's for the patient. So it's a free app, and you can download it and track your symptoms. You can put in there your medication. It will remind you to take your vitamins and minerals. It will remind you to take your medication. And you, every day or every other day, you can go in and say, headache is worse today, or it's better, or whatever. And it produces graphs. It's lovely, a really visual way of seeing how you're getting on. So people can track their improvement or otherwise. You can also download a report and send it to your doctor, and you can put lifestyle in there, your food, everything. It's amazing, and it's so helpful for patients. Now it's all confidential, and you know, we don't know whose data it is, but it's very useful for us to look at the data in an anonymized way. Okay, so I went on to BBC Look East News in October, and I asked patients with long COVID to download this app, and 2,000 of them did. So we very quickly had information. That's the beauty of the apps. You can gather information so quickly, which would take months and months and months, if not years, if you were doing a study. You know, I mean, it can take 6 months to get ethics approval for a study, never mind anything else. And then you so we had all these people download this app, and they put in all their symptoms, and lo and behold, all of their symptom profiles matched those who have MCAS and histamine, high histamine, all of them. And they all had on average at least 7 symptoms, which is, you know, so headache, rash, insomnia, fatigue, whatever, they all had at least 7. And then I just couldn't wait to get my hands on the patients themselves, because I wanted to ask them what their previous history was. And anyway, I had to open a long COVID clinic, because my ordinary clinics are so full. They're full till April, I think, with menopausal ladies, some of whom have got MCAS and histamine intolerance, and some of whom haven't, because we believe that it is 17% of the population. Literally 17% of the population have got MCAS, mostly undiagnosed. So it's frequently seen and seldom recognized. So GPs are seeing it all the time in their IBS patients and so on and so forth. Anyway, so I opened a long COVID clinic for two sessions a week initially. Now I'm afraid it's only one because I'm so busy. And I started seeing these patients. So now I have consulted with 20 long COVID patients. They all have a history suggestive of MCAS previous to their coronavirus infection. They all have very obvious MCAS or atopy, at least, with funny rashes, eczema, troublesome headaches and things like that going on in their previous history for decades. And then when they've caught the coronavirus, it's then set up this high histamine and this sort of overstimulation, which has then brought all these symptoms out more and more to the fore. That's my theory.
Are there more women in that group?
Yes,
yeah.
Yes, more women than men, yeah.
And why?
Well, because, if we believe that they are connected with MCAS, 80% of the patients who have MCAS are female.
Yeah.
We haven't been able to identify a particular gene that causes this. It's probably a combination of genes. And that's the other bit of research we're doing. So we've got these 2,000 patients plus who are, and more hopefully are downloading it, because the more information we get, the better, to see the profiles. Then what we would love to do is see which treatments help which profiles the best. Now, it may be that all the profiles are the same and they all respond to the same treatment, but it might be that there are some subtle differences. If we've got large numbers of profiles, we'll be able to tell that with some future research. And also, I've forgot my thought now. What was the other thing I wanted to say? Oh, it'll come back to me, don't worry. I'll
do another question, it might come back, and I'm so glad it happens to you as well as me. Does MCAS lead to joint hypermobility syndrome, or the other way, vice versa, or is it just combination?
So 80% of patients who have histamine intolerance and MCAS will have hypermobility. It's difficult to know which is chicken and egg, isn't it? I believe it's all coming from the mast cell, and the mast cell is causing the hypermobility, and in some patients it will express like that because of probably their genetics, and in others it won't. So it's a combination of the two probably. And again, if I really, when you're feeling up to it, have a look at the Pentad lectures, because he does it all beautifully with diagrams. I can't do that, and picture it, you know, lots of pictures, and it's so lovely. And he talks about, in the second lecture, he talks about this wheel, this tire of a bicycle having lots of punctures in it. And one puncture might be IBS, another puncture might be leaky gut syndrome, another puncture might be migraine, another puncture might be EDS, another puncture. And he said, unless you patch up all of the punctures, you can't use the tire. So it's, you know, it's important to think about everything for everybody in the whole.
Okay, another question. How well understood is the link between MCAS, stress, anxiety, and neurodiversity?
So I mentioned in my presentation about the body releasing adrenaline to try and lower histamine, and that causes anxiety and panic attacks. That we certainly understand. There has been some work done on depression and various other chemicals that will be passing through the membrane into the brain. The other thing that can happen is that the blood-brain barrier, which is a barrier that's supposed to stop toxins going into the brain. It's the body's mechanism for protecting the brain in this lovely sort of case, so that chemicals can't all just pass through to the brain. The blood-brain barrier is absolutely critical in keeping our brains clean. And in these patients, the blood-brain barrier starts to break down. And that's where I think the elastase 2 comes in. And so toxins pass into the brain, and that causes the brain fog and the cognitive dysfunction. So you can't quite think, you know, and get your words out or whatever it might be. And so we need more research, you know, we need much more research. This is a very young science, and it'll be absolutely fascinating to have the data from people and to be able to start putting this together.
I think it's absolutely, you know, fascinating. And I think as we're getting more involved in it, I think everybody's sort of learning about it at different levels, but hopefully we'll get there. Okay, who's the best person, apart from you, to be asked to be referred to for a diagnosis in the UK for MCAS?
Oh, it's a difficult one. There's not very many of us here, but I think long COVID is going to put it on the map, actually. I mean, I'm hoping that the long COVID clinics that they're planning to open, at the moment, I don't think they've got a clue what to do with the patients, but I'm hoping to have some kind of input and influence into those, if I can, so that they would at least consider this. I think it should be a multi-discipline team looking at these patients, and this should be firmly on the table as something that we need to be, you know, eliminating other problems, like, you know, if they've got a tachycardia, they haven't got an arrhythmia, et cetera, as well. But when you come, you know, everything is negative, then this is how we treat people. And that will educate all these specialists about this condition. And then I'm hoping that once the long COVID is sorted, which of course will take years, these will become centers of excellence for mast cell activation and histamine intolerance, because everyone will have the skills and they'll realize how common it is. So we believe it's 17% of the population who have dysfunctional mast cells. And that's why I said it's very frequently seen but seldom recognized, because the GPs are constantly seeing it all day. And it's the patients they put into that unexplained symptoms box. You know, everything, all tests normal, but they still have these problems. I don't know what to do with you.
And so would you say MCAS presents in the same way as other viral triggers has in the past? Like,
yes, so other viruses can cause it in exactly the same way. So a lot of my patients, they give a history of being super ill with glandular fever when they're 17 or something. And then after that, their health never quite settles down. It never quite gets back to normal. Yeah. And therein lies the problem. Once they're sensitized, it seems to sort of, you know, so yes, infections. And also the other thing is, sorry, while I just think of this, Jane, keep your thought, is that if you have an infection, you must get it treated as quickly as possible, because that will be keeping your histamine up. So whether that's a urinary tract infection or infected eczema or an infected, fungal infection on your feet or something, or your toenails, please get it treated.
Interesting. Okay.
That should be an absolute priority.
And that might be the same for an injury as well, if it's acute, because your stress levels would go up, and then your pain, and then I'm thinking, I'm just
you're right.
Okay. I have, this is a question, not me. I have a milk protein allergy, so my NJ feed is soya, but this is high histamine, and I have suspected MCAS. So could this be causing me more problems? I don't think there's an alternative, and I have gastroparesis.
Yes. Yes, and the gastroparesis is part of the autonomic I can't say the word.
Oh, good. I'm glad you're happy.
Yes, it's all part of that their gut gets very lazy, very slow, doesn't like to be, which is awful, because when you imagine if you get constipated, then your body is trying to get rid of toxins into your stool. And if you're constipated, it then reabsorbs them. It reabsorbs them, and then it takes them back to the liver to detoxify again. So it's wasting so many vitamins and minerals, processing the same thing again and again, going round and round and round, which also then stresses the liver. And so constipation is something to be avoided at all costs. And there are various things that help different people. There's something called Oxytec, which you can buy online, actually, which a lot of patients find very helpful with their gut motility. Oxytec.
I think she's saying that she has to have milk, but she's allergic to soya and milk. So is there another kind? I think that might be for a gastroenterologist or someone like that. See if there's a different type of milk.
Yeah.
I'm not quite sure.
Or a nutritional therapist might be good to see.
Oh, we did have one, actually. We had a dietitian.
Yes.
Speak for us.
Who understands this kind of thing.
Yeah. That might be good. I've got another question. Can you recommend any pediatricians for MCAS in children?
Yes, I can. There's a Dr. Patel. Now, what's her first name? Begins with V. Her first name begins with V. I will get my secretary to send you an email. Vasha Patel, I think it is. She's a pediatric consultant who has studied functional medicine, and she treats people with MCAS. So she's where I send all of my, because I'm getting a lot of emails. Vasha Patel, thank you. Dr. Vasha Patel, whoever's done that. Thank you, Becky. That's great. So Vasha Patel is your person. I'm getting a lot of emails from people saying, my children have got this. What do you think? Can you treat them? And I can't. We're not allowed, unless you're a pediatrician, you can't see under 18s.
Right.
So, which is quite funny, because I used to see 13-year-olds in my contraception clinics. I was allowed to do that. But I'm not allowed to see under 18s if they have this condition. But anyway, it's fine. Vasha Patel is the person you want to go.
I know you've got to go, but I thought it was so interesting about children, and they're not really ever or even diagnosed with EDS, let alone anything else. But I know from my children and the other members' children, I mean, if you see that eczema as a baby, I was on a nice advisory group. That's got to be a sort of indicator of like, ooh, watch this, hay fever's coming, asthma's coming, what comes next?
Yes.
And I think it should be taught at that age.
Yeah, and if you look at the Pentad lectures, he talks about people marching along, and they, a lot of young people will have some of these symptoms like the postural hypotension, and that's quite normal in a way for sort of teenagers to have. And the boys will march into normality, and the girls will march more and more into abnormality. And that's what we want to try and nip in the bud, and try and get everybody as stable as possible, as young as possible, because it gets harder and harder to treat as you get older. Anyway,
that's
I think
brilliant. I know you have to go. I know you've had another long day, and we've got other questions, I know, because they're pinging through, but I will pass them to you, and you'll
Yes, lovely.
and we'll do that.
That's great.
Can we just have a picture?